Welcome back to Conversations with Therapists. Today I'm joined by Tamara Harrison of Evergreen State Counseling. Tamara, thank you for being here.
Yes, thank you for having me.
So, could you share a bit about your journey into working as a therapist? What drew you to specialize in OCD and BFRBs? And could you briefly share for our viewers who might not know what a BFRB is, what that is?
Well, I always knew I wanted to work with people in general, but I started my studies in international affairs. So I wanted to work in third world countries for human rights. But then I got into the political courses and the economics courses, and I'm not cut out for those. And I switched over to studying therapy. When I graduated, I worked with many different populations, and OCD kind of landed in my lap. During the pandemic, I got recruited to work for a very well-known organization that trained me this is like the nation's top OCD specialists. So I got such good training from them. And it hit close to home because I have a lived history of OCD starting from a child. And once I learned the treatment and how effective it was, both personally and professionally, I was hooked and decided that I wanted to devote my career to OCD and to related disorders. So anything underneath that category of OCD. And one of those is BFRBs, which I'm happy to explain more about. So BFRBs are something that is less well known as a class of disorders, but so many people struggle with it. So this is compulsive nail biting or skin picking or hair pulling. And this isn't just like regular grooming, it's when it becomes very all consuming. It might cause harm to the person's body from the amount they're picking or pulling. And it really interferes with their life. So that is under the umbrella of body focused repetitive behaviors. That's what BFRB stands for. And it shares the same kind of parts of the brain as OCD. So it's underneath that umbrella. And so I consider myself to be a specialist of anything that is related to OCD.
How would you describe your therapeutic philosophy or orientation, like CBT, ERP, ACT, etc.? And how does that inform the way that you treat clients with OCD and BFRBs?
Yeah, great question. So my therapeutic approach has changed over the years. I've been working with OCD and BFRBs and related disorders for about 10 years. And as I still stick to the tried and true gold standard evidence-based models. So that is for OCD, it's exposure and response prevention is the one that I use the most. And then for BFRBs, it's the COMB model, which is comprehensive behavioral management of BFRBs. But within that, as I've learned and grown and learned from all my clients and see what works, I really infuse a lot of other modalities as well. So I'm very trauma informed. I don't know a lot of people who haven't had trauma. And so as we come across traumatic things that interfere with someone's primary diagnosis, we might do some parts work, which is kind of the layperson's term for IFS or internal family systems. It's really effective. I also use a lot of like inner child work, reparenting of our nervous system, and then the tried and true CBT, of course, is infused in all of that. I use narrative therapy, I use behavioral therapy, but for OCD, I really just love the combination of exposure and response prevention plus acceptance and commitment therapy, which is known as ACT. And that's kind of the idea of we can tolerate distress, but live a life that is aligned with our values.
That's really awesome to hear about the different combinations of techniques that you use and how you really tailor it to this client's specific needs and really empower them to heal.
As I've grown, I've just realized that we can have these evidence-based models that do work, but we as humans are just so complex. And so it's really, really important to me to treat that person holistically. And if someone has OCD, not every symptom can be wrapped up as OCD. So we don't just throw exposure therapy at everything. We really take a look at how do the other modalities that can help this person actually meet this person better in a way that isn't just a 1, 2, 3 ABC approach.
What would you say the, I guess, success rate of ERPs are is in comparison to just ACT acceptance and commitment or just CBT? Do you find that clients tend to, I guess, relapse into certain behaviors and they have to start the exposure and response modality over and over again? Or is it something that can be done sometimes just once and have it stick, so to speak?
Yeah. So that's such a good question. And I'm really passionate about this because most people come to me after years and years of talk therapy and misdiagnosis. Most people with OCD, the statistics say it takes about on average 12 to 17 years from the onset of symptoms to actually getting a diagnosis and getting the right treatment. So by the time a lot of folks come to me, they have been in extensive talk therapy. And what we know is that just traditional CBT or other modalities for OCD not only don't help, but actually make it worse. So essentially, you're paying someone to engage with compulsions with you and fuel that OCD cycle, which is devastating. So I do see ERP as being the benchmark for what we need to do, as well as all the other things that that person might need. And as far as making it stick, we know that if a person is open-minded to the approach, because it is counterintuitive, and if they are patient with themselves and if they're very consistent, then they will get results. I believe in that so wholeheartedly that ERP does work. It can be difficult for sure, and we need to troubleshoot the areas that might be sticking points for someone, which is why it's really, really important to me that we don't even start ERP until that person really understands why they're doing this. We call it in the OCD world cruel and unusual treatment because it does feel so hard to go towards your fears. My OCD clients are the bravest people on the planet because I'm asking them to actually tolerate the horrible thoughts that their mind is throwing at them, but we teach them how to engage with their thoughts in a different way. And I always tell people that if they go through ERP treatment for their OCD, they come out as like um, a Joe 2.0 or a Mary 2.0 because they are such a better version of themselves because they've learned to tolerate uncertainty. So an example is when COVID happened, everyone was freaking out. People who didn't have OCD were freaking out and acting in very obsessive compulsive ways. And, there was so much uncertainty. And if we think about OCD as being a disorder of uncertainty, being intolerant of uncertainty, people who had gone through ERP already had actually were able to tolerate COVID and the uncertainty of COVID so much better than the general population. And so that is a testament to the idea that not only does ERP work so well for OCD, but it actually works for all of life. And so once people have the tenets of ERP nailed down, usually it generalizes out to all other areas that they might struggle with in terms of uncertainty or obsessions and compulsions. And so I find that people might need like a little booster session now and again, but once they really understand and consistently do the treatment, it does stick.
I just thought of a question as you told that story about COVID. Is ERP something that could be beneficial for someone who doesn't have OCD or even generalized anxiety? I don't know anybody who doesn't have generalized anxiety these days, but is that something that the general population could benefit from, even if it's in a different format than it might be used for someone with OCD?
Such a great question. And yes, 100%. I think everyone needs ERP. And I actually use ERP for any form of anxiety, whether it's a phobia, whether it's social anxiety or panic attacks, or just kind of over like all-consuming worry that people can't control. ERP is fantastic for all of it. So even for people who are like, I don't even know if I have OCD. I know I worry a lot and I know I ruminate a lot. ERP is so great for that because if you think about it, life is one big exposure. We are constantly navigating risk, even in ways that we don't really think about. Every time we go outside, we navigate risk. And any way that a person feels limited by their fear, ERP is just an amazing, amazing modality for it. So yes, ERP for everyone.
Can you share a fictionalized or anonymous case example of someone who struggled with both OCD and trauma, and what the treatment process looked like with you as their therapist, and what were some key turning points in that?
So I think in general, someone might have a predisposition to OCD already. There's a really large genetic component of OCD, but they may not ever really deal with it until something really hard happens. And in those cases, we know that OCD latches on to the things we care about the most, so our values. So if someone has a death in the family that was really, really hard, they might all of a sudden feel very, very hyper vigilant towards the idea of causing harm to someone else. Or what if I do something that causes intentional or unintentional harm to someone as a result of my actions? And so they might become very, very hyper vigilant towards anything in their daily life. But the thing that is coming out of is there may be very traumatic experience about this death that happened to them. And so what I really like to do is offer that person so much compassion towards the part of themselves that is just trying so hard to protect them. And that's where I really like to use parts work. Like, this part of you is working so hard to keep you safe, but it's working too hard and it's restricting your life. And so how do we really have self-compassion and understanding and nervous system soothing for that part of you that is really traumatized by this event, but then also use the ERP to stop the compulsions and to stop the rumination that comes alongside of it. So we would talk through the trauma. We would access that part of us that is operating out of the trauma. And we would use kind of a multi-pronged approach for that person to really touch on the trauma while also navigating the OCD. And that can be I know someone who had a very difficult medical experience, and now they have really constant health anxiety. So monitoring their body, scanning their symptoms, really, really concerned about doing anything that might cause harm to themselves. And so how do we work through that medical trauma that really, really was so awful by giving them that nervous system regulation, that parts work, while also slowly and gently exposing them to situations that they're avoiding now that would actually really kind of benefit their life to get back to. So those approaches are where, or those cases are where those multi-pronged approaches work really well.
To wrap up, for listeners who may be dealing with intrusive thoughts, perfectionism, constant worry, or even trouble focusing, what are 2 to 3 practical strategies or even mindset shifts that you often teach in therapy to help them begin to feel more grounded and empowered?
At first, I do a really strong, we get to be almost our own personal data scientists. We want to really understand, what are the thoughts that come up? What are the triggers? And what are the ways that we're dealing with it? And this is why I pay so much attention to the mental compulsions, because the physical compulsions are easy to identify. We can see them. The mental compulsions are so much harder. They're so much more automatic. They're so much more hidden. And so we spend a lot of time examining, what are the ways that your brain responds to the intrusive thought or to the worry. And so once we have a really clear assessment of that, I have a framework that allows someone to track those over time. Once we have a really good idea, we know how our brain works, we understand it, we can catch it when it's happening, then we dive into the ERP. And what I do is I practice with people in sessions. So we start with a really low level exposure, like a 2 or a 3 out of 10 on the distress scale. And we identify, what is a way that we can expose ourselves to the fear, but respond differently. And that's where we use all kinds of approaches. That's where I intertwine acceptance and commitment therapy, where I can tolerate this internal experience. I can accept that my brain is doing this thing while going in the direction of my values. And so we use a lot of diffusion techniques. Like, I notice I'm having this thought. oh, there's OCD again. There's that image again. And so we identify that, and even just that little space between you and the thought can allow you to separate it from it a little bit. Other techniques we might use is almost calling the OCD by a different name. So some clients come up with really creative names for their OCD, and they personalize it. Some people say like to see OCD as a bully that torments them. And so they use the I am not reacting to the bully approach. Other people resonate more with this is just like a scared child having a tantrum. And I can see my OCD almost like a toddler that is tired and hungry and is believing things that aren't true. And I can treat that child with compassion while also doing something different. So we can use those approaches. And then really we kind of we make this hierarchy of our exposure, starting from the lowest level and working up to the highest level, so that people can see I have power over my thoughts. I don't have to listen to them, and I don't have to obey what it's telling me to do. So those are a few things that we might do.
I've actually heard about in a different context, I think more for anxiety or even depression or really anything someone might be dealing with mental health wise, kind of calling things by a name.
Yeah.
It provides a lot of separation and allows anyone to take a step back and realize that they are not their OCD, they're not their anxiety,
Yes.
they're not all consumed by it.
Yes.
And use that as a tool to look at their OCD or their anxiety or whatever it is at face value, and how can they deal with it and not fuse together with it. Going back to the parts.
Totally. 100%. And what I'd love to say is that because OCD attacks our values, it's really important to me that we don't ever take someone away from their values. So typically when OCD attacks someone's faith or relationship or the people they love or the things they love to do, we never take that away from them. We actually just remove the fear so the person can live their life of values from a non-obsessive compulsive way.
Well, Tamara, thank you so much for being here. I learned so much, and I'm so excited for our viewers to now have a much better sense of you and your amazing practice, for them to be able to reach out, learn more about all the wonderful work you do. Thank you again.
Yeah, thank you, Devorah. I love talking about this. It's my passion, and really grateful to spend this time with you.